I think at 10 minutes over, we've got to kill it. And I must be honest, I'm okay with you looking. It's the Well, it's not going to be. Well, yeah.
Should be fine.
Yes.
That's why I'm going to sit here, so I've got enough space to get out, so I don't go backwards.
If I can have everybody's attention, if we can please take seats. Otherwise, you'll have far less time at lunch for that very important networking. I must be honest, it's really amazing to see so many people from the shared care record community. It's been so long that we've got together. I'll tell you what, I know this is a bit naff really. I'll just take a photo of everybody, just because we don't really get this opportunity that often to catch up. And it's really important we do catch up. All the brilliant and amazing people in the room are going to make a difference of making shared care records work. Every one of you is going to make that difference. Every one of you's got lived experience. Every one of you has solved problems. And we need to use that hive mind, so when you solve a problem, you solve everybody's problem. So, sorry, I went straight in there. I'm Lee Rickles. I'm the too many titles. I'm the director of the Yorkshire Umber Care Record, and it's brilliant to host this event for all the for the shared care record community. And we've got a really good couple of keynote speakers who I'll introduce, but there's some housekeeping I've got to cover. So first of all, we do have a fire alarm at 11 o'clock. It is planned. We haven't got an actual fire, so just let that one ride. If it's not 11 o'clock, we need to follow the appropriate fire exits. They are around the room, and we end up walking down to Eyre Street, which might mean nothing to anybody who isn't from this area. So main thing is go through the emergency exits. Toilets are downstairs, where you come in and got your badges. So hopefully that helps and makes sense. And obviously teas and coffees and refreshments. Food will be in there as well. Okay, you've all been allocated an A or a B. The red. I didn't realise it was red. You'll stay in the ballroom. To be honest, you're going to have your step count reduced today. You're going to have less steps. So if you're into stepping, you might need to talk to me afterwards. And if you're on B track, you're on the ground floor in the Palm Court room, which you'll have passed on your way in to the event. Don't worry, you'll sort of get used to them. If you're in the B track, you're generally going to be on the B track for today and tomorrow. If you're on the A track, you stay on the A track today and tomorrow. If you're going to make it really complicated, we'll have to have the people who are managing rooms talk to you if you decide to use the wrong one, because they do have A's and B's on. Okay, so got two great keynotes this morning. We've got Melissa Mead, MBE. Melissa is an ambassador for UK Sepsis Trust, and a key role is raising awareness for sepsis after her son William died in 2014. And she's going to, explain that in a presentation, what we could have done differently, how we could prevent that happening again, because that should never happen to a parent. And we've also got Rowan Prichard-Jones, who's the medical director of the NHS Cheshire and Merseyside ICS. Rowan's going to give us a bit of a what's the art of the possible? Where can we go? How can we make that difference? So, I'm trying to keep down to 5 minutes, and I think I'm just about there, for those of you that know me. So, it's my great delight to introduce Melissa to do the first keynote.
Thanks, Lee. It's really wonderful to be here today in front of real humans. It makes a change from being on Teams. I'm going to talk to you today about my son's story. And just at the beginning, I know that some people have been personally affected by the child loss. And if you do need to take a moment, my son's story is quite harrowing. And if you do need to take a moment, please don't. I won't be offended if you need to leave and take a moment for yourself. The golden thread that ran through the RCA following my son's death was that of 4 providers that were looking after my son, only one of them had access to his records, and that played a really pivotal part in his death. So to give it the context, I'm just going to talk to you about his story. So this is William. He would be 9 now, and he died in 2014. So to give you an idea, he was what was known as an unremarkable baby. I went in, I had the baby, we went home. He was fine, I was fine. It was a good pregnancy. And I had 9 months of maternity leave, and it went swimmingly. He wasn't a poorly baby. He was known as a Gaviscon kid because he couldn't keep his milk down. But he wasn't really poorly at all. I started back to work in the September 2014. William went off to nursery. Within a couple of weeks, he was sniffly, eyes full of everything, snot, kids lick each other in places that they shouldn't, and it's germ fests. So we fully expected that once he started nursery, we'd start to encounter these sort of problems. But after about a week, he started to look like he was struggling to eat, and now obviously being only sort of 10 months old, I couldn't ask him if his throat was sore, I couldn't look in his throat. So I took him off to the doctors, and he said, goodness me, I don't know why he hasn't sort of started having fevers and things, because he had raging tonsillitis. So we kept him off nursery. He actually developed scarlet fever. He was on the right antibiotics, and he recovered really well. He went back to nursery, and within about a week, he started coughing. And I now know it's called a self-limiting cough. So he would sort of cough and then get on with it. It didn't wake him up, it didn't stop him doing things, and it wasn't disturbing him at all. After about a week, I suppose, I said to my then partner, I think we should probably just take him in. He's sort of going on a little bit longer. So I took him into the doctors. Chest is clear, ears are clear, everything's clear, it's fine. You're a first-time mum, you're bound to be worried. It's just a viral infection, just carry on. So I was quite reassured by that, because that's what I anticipated the answers to be. So off we went. After about another week or so, his coughing was slightly longer, the coughing fits lasted longer, were more frequent, so I took him back to the doctors again, and I had the same response. We then head into November, and we celebrated. I actually had him on my birthday, so we celebrated his first birthday and my birthday. And I said to Paul, that's his dad, I said, oh goodness, he seems like he's losing a little bit of weight. You know, he was quite active by this point, pulling himself up, roaming around furniture. And Paul said, well, I think it's probably because he's a bit more active, you know. And then one morning, he coughed so much while he was eating his breakfast that he was sick. Now, it wasn't a tummy bug sick, it was literally that he'd just eaten his toast, he coughed so much, he brought his toast up. But I said to Paul, that's not right, he shouldn't, you know, be coughing so much that he's sick. So off I went to the doctors again, and I asked to see a different doctor, and I don't know why. At the time, I had no medical background, you know. I just thought a different pair of eyes might help, you know. And the first thing that she said when I walked in was, oh, I can see the previous doctor said that this is viral. And I said, oh, okay. I said, well, do you want to examine him? And she listened to his chest, and I can remember her words, and she said, there are some crackles on his chest, but little chests are very difficult to listen to. The sounds reverberate off the upper respiratory tract. And I said, but this has been going on now for about 5 weeks. And, you know, he's vomited this morning, and do you think he should have some antibiotics? And she said, no, I don't think so. She recognised that we have a really, really strong family history of pretty bad lungs. I have brittle asthma. So she gave us a Ventolin inhaler and one of those little aero chambers. Now, William would tolerate this. So he was a very docile baby. This is a bit relevant for later in the story. He was very docile. He'd let the doctor put the thermometer in his ear. He'd let you put the mask on his face. My other child's quite feral. He won't let you do anything. So he took the inhaler quite well. So we gave it to him before bedtime. We gave it to him before eating, before going outside, the key kind of moments when you start to cough. It didn't really make a difference, though. And so we're now into December, and it was the 11th of December, and William came home from nursery, and he had spaghetti bolognese, and he covered himself in it, and we had a bath, and then we built a den. And it was probably the last time I ever really heard him belly laugh. He woke up in the night, and he was crying, and his cheeks were bright red, he was dribbling, his fists were going in his mouth, and he was cutting 5 teeth at the time. So I did what most parents would do. They gave him Calpol, and I cuddled him, and he went back to sleep. He woke up the next morning, and he sort of pushed his breakfast around the plate, and he wasn't really interested. So I said to Paul, I might keep him off nursery today. It's only Friday anyway. But as soon as I said the word nursery, he perked up, and he crawled towards the door. That was his thing. He loved nursery. So I took him into nursery, and I said, look, he's been up a little bit in the night. He's had some Calpol at 1 a.m. You can give it to him sort of later morning. He is teething, so he might be a little bit off. I get a phone call at about 11 o'clock to say that they'd given him some Calpol. They'd noticed that his temperature was about 37.9, and he was really tired, and he'd refused his food. So they'd put him down for a nap, and I said, right, as soon as he wakes up, I will come in and get him. I get a phone call at 11:30 to say that he's still not woken up, and they've taken his temperature again, and now it's 38.4. So I said, right, I'm coming in. So I rang my GP surgery. Now, this was Friday, the 12th of December. I didn't know it at the time, but our hospital was on black alert. I live in Cornwall, so we have one acute trust. So the rules were at the time, unless you had arterial spray, you weren't coming in the front door. And they said, we've got no appointments, it's Friday. I said, what about the duty doctor? And they said, no, that's full. And I said, but he really needs to be seen. You know, his temperature's going up, he's not very well, he's not himself. We're going into the weekend. So they said, right, come in at the end of the day, sit and wait, and we'll see you at the end of the day. So I thought, right, okay. So we took him home. You can see from this picture, well, you probably can't actually, his lips are very, very pink here. And this is a little bit relevant later. And he was really feeling sorry for himself. He was snotty, he was miserable, he was just generally unwell at this point. We got into the doctors, and we went in, and it was 5:40. And his temperature by now was 40.1. And he was combative. He was not himself. He was not normal. And I said, this is really unusual for William. He did not want the doctor to put the thermometer on his chest. He did not want whatever that thing is that you put in the ear to do his temperature, is called. And he just wasn't himself. I managed to calm him down, and the doctor managed to do a good examination. and his chest was clear, his ears are clear, his throat is clear. Don't worry, Mum, this is just a viral infection. He's teething, cowpole fluids and plenty of rest. Now, as I was leaving, I said, oh, when should we take him in? This is Friday night. And he said, don't worry, it's nothing grisly. There was absolutely no safety netting at all about what worse looks like. I had no idea. So we went home, he went to bed, and through the night, his temperature started to come back down. And the one thing the doctor had said is get on top of the temperature and he'll start to perk up. So sort of getting into late morning on the Saturday, and I said to Paul, his temperature's coming down, but he just seems so much worse. I said, I'm going to ring 111. And he said, God, they're going to think you're mad, We've just been in yesterday and you've been in all these times before. And I said, yeah, but he's just not right. We had a leather sofa and he would not tolerate clothes on him. It was difficult to get this vest on him. So I put the quilt on the sofa so that he would at least not feel cold. But he felt really cold to touch. I rang 111 and they asked me to take his temperature 3 times during the phone call to get an average. And it was 35.4. And they said, that's good, you've got on top of his temperature. So I thought, right, okay, that's good. I said, he's not eating since Thursday. And anytime I give him any drink or, milk or water or anything to tempt him, it just brings it back up and it's quite green. I said, he's not had a poo and he's not weeing. And they said, well, he's not going to wee if he's not drinking anything. So again, I felt reassured. I said, he's really quite cool to touch. I can't, he feels quite cold. And they said, well, he's going to be if he's not got any clothes on. So I thought, right, okay. They said, this is a non-urgent 6-hour callback. So I thought, oh, right, okay. And so we put the phone down. That was about 3:00 in the afternoon. And this is the last photo that I've got of me and William alive. If you can see the photo, he has no colour in his lips now whatsoever. I put him to bed and I whispered to him, good night, sweetheart, I love you. And that was the last thing that I ever said to him. I put his little arm around his reindeer. And if any of you here are parents, you know that when you put your child down, you stealth out of the room because you don't want to wake them up. And I stood at the end of his cot and I thought, you're just not right. Something's not right. I went back downstairs and I rang 111. Paul's got ants in his pants at this point, thinking I'm neurotic. And I rang 111 back and I said, I really need to speak to a doctor. I really need to speak to someone. They said, we're going to have to wait. So I waited and I was patched through. And the first thing that the doctor said to me on the phone was, I'm so busy tonight, I've got a waiting room full of people. And I immediately felt like, my goodness, I've got to get on with this, At this point, the doctor said to me, could you explain to me what's happened? He had no access to William's records whatsoever. I've been up for 48 hours. I'm pulling my hair out. I'm really worried. I'm quite fraught. And the onus was on me to recount every single appointment, every single symptom, everything. And they actually played this phone call out at the inquest, and I was very proactive. I was leading all the questions. The doctor was very reactive to me. And I said, yesterday I had this really high temperature, now it's very low. He said, that's good, you've got the temperature down. I said, he's not had any wheeze, he's not been to the toilet. And he said, well, he won't be if he's not taking on any fluids or food. So I felt, again, falsely reassured. He said, if he's asleep, the best place for him is in bed. Keep up the cowpole fluids, and if you need to. He's going to be right as rain in the morning. So I thought, right, okay. I checked on him at 11. Now, Paul and I were due to get married on the Monday, and so I was faffing, is the right word. And Paul said, you've got to stop faffing, we've got to go to bed. So I went to bed about 11 o'clock, and I checked on him about 1, 2 in the morning, and he was sort of lightly sleeping. About 5 o'clock in the morning, I heard some rustling, and we had one of those little baby spy monitors, and he'd just leant up to take some drink of his sippy cup, and I thought, oh, that's good, he's thirsty. He'll be, ready for breakfast in the morning. I woke up just after 8, and I thought, well, that's strange, William's not awake yet. And I went to the loo, and I didn't have my glasses on, and we've got blackout blinds in his bedroom, and I went in, and I could smell that he'd been to the toilet, and I thought, that's really odd. I went over to his cot and I stroked his cheek and it was warm and he didn't move. And I knelt down and put my arm through the bar of the cot and I stroked his arm and it was quite cold. and he didn't stir. And then I stroked his side, and he was stiff. And I shot up, and I opened the blind, and I could see that he was dead. His eyes had fallen open, and he was staring straight through me. I started shouting to Paul, "My God, William's dead, he's not breathing, he's not breathing." And he ran in, and he lifted William out of the cot and laid him on the floor, and he stayed in the position that he died in. I rang 999, and I was going 1 and 2 and 3 and 4 and 1 and 2, and I couldn't open his mouth to give him rescue breaths because he was in rigor. The paramedics come thundering up the stairs at 3 minutes and 44 seconds. I can remember it because I can still see it on the little digital display, and we were very close to the ambulance station. After 7 minutes, they turned to me and said, "I'm sorry, my love, but he's gone." And I laid with my cheek on his bedroom floor, and I begged him to wake up, knowing he never would. We were conveyed to the hospital, and this is our reality. This is the reality of not thinking sepsis. This is the reality of the outcomes of the RCA. We're compromising care. I was allowed to hold him 16 times after this photo was taken. I'll just move that on. So, 24th of December, I get a call from the coroner who says, "We've got William's body back now, so we could have him." And she said, "Did William have a cough?" And I laughed like a nervous laugh. I said, yeah, he'd had a cough for ages. And I said, "Why?" And she said, "Well, he had pneumonia." I said, "What do you mean he had pneumonia?" I said, "I took him to the doctor's weeks, and then 36 hours before he died." And she said he had a collapsed lung, and he had a pleural effusion where there was 200 mils of viscous fluid in his left lung cavity. I actually spoke to the medical examiner that did his post-mortem, and he said that fluid would have been there 7 to 10 days because of the viscosity of it. I said, "But the doctor said he had the clear chest," and he said, "No, there would have been no air movement in his chest. There would have been dull air movements in the right-hand side. He had an abscess in his upper lung lobe, and he died of sepsis." I said, "What the hell is that? I've never heard of that." All of these seemingly insignificant symptoms that William was displaying in isolation might not mean anything, but together they're catastrophic. No one had told me about sepsis. No one had told me that the lack of urine output was a sign of sepsis. No one had told me that the significant drop in temperature was a sign that his body was failing. No one told me that the funny cry that he was making during that 111 phone call, which was played back at the inquest, was him in respiratory distress. I did not know why this had happened. We then had to endure a 3-year protracted battle of an investigation to find out what had happened to William, because everyone said, of the 4 providers involved, that they couldn't have done anything differently. But what actually happened were there were 16 failings in his care and 4 missed opportunities to save his life. These are the RCA outcomes. And there was the pressure on GPs at the time not to prescribe antibiotics. And I'm an ambassador for the Sepsis Trust, and I fully promote antimicrobial resistance. But when it's clinically evident to do so, antibiotics should be prescribed. The difference is that there were no tests done on William to tell us that it was actually viral and not bacterial. In those weeks leading up to his death, he had a bacterial chest infection. If he had had antibiotics, it's likely pneumonia wouldn't have been on set. However, even if it had, he'd have been on the radar. Different antibiotics would have been given, or he'd been taken to hospital. Sensitivity of 111 pathways and the need for 111 disposition standards, and this has changed significantly since William died, which is great. And a collaborative nationally on sepsis. The Southwest and local is the shared care records, which is why you're all here today. The onus was on me at every single point of every single appointment to recount everything that I thought was relevant. But you see, I'm not a doctor. I'm a mum. And the one thing that didn't happen is that I wasn't listened to. When I said William is just not right, that means he's just not right. That's for the doctor to tell me why he is right, not why he thinks he's right. That's the difference with sepsis, is if it's just a viral infection, tell me why it's only a viral infection. Don't just tell me you think it is. But you're all here today because of shared care records. William slipped through the net. There were multiple failings in his care. But one of those failings was that 3 of those providers that I spoke to in the 36 hours before he died had no access to his records, could not see the history, could not see the pathology, could not see the chronology of events. And so what I ask of you today is that you just remember, because a lot of you here won't see patients on the front line, you won't be face to face, but everything that you are doing is going to benefit someone like me or someone like William, and not just benefit, but benefit them with their life. And that's really, really important. So I just want to thank you, because William died 8 years ago, and none of this shared records was on the horizon at the time. And now it is. And so, you know, I want to thank you for all the work that you do. And that's it, really. I don't really have anything else that I need to say. So I guess I'll just hand over to Rowan. But thank you for listening today. Thank you. You introduce? I don't know if I should introduce Rowan. I'm sorry.
Okay. A man who needs no instruction.
I don't know you can really follow that, to be honest. I'm a doctor, I'm a dad. You've all got families. This sensation that you've got right now, this discomfort, use this today. Use this to channel your energy into what we need to do differently now. If someone can be this brave, think how amazing you can all be when you put this stuff together. So, where have we got to get to because of the individual? My working life is as a plastic reconstructive surgeon. I do a lot of skin cancer work, complex reconstructions, and it has to be every day about the individual patient, of course. My journey through medicine into the role that I have now, you're going to get a momentary whistle-stop tour because it's created the way I view the power of getting it right, not just for the individual, but for our entire communities, our entire populations. So us plastic surgeons, we live in a world that demands a reaction to challenge. We're principles-based. We'll step into anything, anywhere, and do things. And whilst this might look some of the more challenged parts of the NHS, this isn't. This is heading out high in the Himalaya. Out in Nepal, we do a lot of cleft reconstruction for children that can't get to a hospital. So we turn a school into a hospital over about 3 days, and we just get on, we do. And we operate through the day and we operate through the night. And it's pretty breezy up there. To get to where we were in the foothills of Annapurna, you had to fly along the edge of the Himalaya. And the joy of it all was that actually normally my ward round is out of theatres and down the corridor and through the doors. And I went through the doors for these post-op ward rounds, but actually it was in the most beautiful garden. And we could see all the kids out of the window of the school in the garden for their post-op recovery, back with their parents and their families. And you learn to adapt in the face of challenge. Hold that thought. The other part of my world that's been an important one is I'm a university academic. I run a lab. We work on chemo resistance in skin cancer. I do some population health work as well, really trying to understand how can we get in and solve the problems that our communities face. And for me to solve the problem, you've got to be absolutely clear what that problem is. Not just for the individual patient, but what is it about entire communities that we need to think about doing differently? And the last part of my life that pointed me into a direction of building a skill set was taking the white coat off and putting a brownie green one on. I was saying to Melissa earlier, by and large, undertaking operations is so much easier when someone isn't shooting at you. And for the most part in the UK, it is like that, I am delighted to say. So having been a consultant, I did a lot of work in digital bits and pieces within the trust. I then found myself 12 weeks before COVID hit becoming the medical director of St Helens and Knowsley. So there's been the steepest learning curve of my career, trying to work out when Imperial said you need 100 ventilators and we could get to 60. And at 3 a.m, you're thinking about where else can we reroute the oxygen? Can we just take it around the outside of the building and do something different? So you had to learn fast, and people like me as the medical director then get thrown out. And it's brilliant doing ITV on the 8th of December. And they go, yeah, put your scrubs on. Yeah, but it's -4. The shivering will really make a difference. And sure enough, it did. So having spent that time as a medical director and seeing what it was like for a trust, I'm now in the job that I do. I look after Cheshire and Merseyside. So our integrated care systems have landed, 42 of them across England. And Cheshire and Merseyside is one of the more complex systems. A lot of integrated care systems might have one provider and we're across one CCG or two. In Cheshire and Merseyside, we have the joy of 9 local authorities, 22 trusts now when we include our North West Ambulance colleagues, and it's nice to see them with us today. 350 GP practices and 1,400 care homes. So there is plenty going on. And as a population, we have our challenges. It's got really high rates of premature cancer and cardiac disease. And 1 in 4 patients here live in poverty. So there's plenty for me to worry about. And let's face it, the rest of the NHS is going through a really, really challenging time right now. We are seeing the strike action that is going on, and so delighted to see that that's looking like it's going to be resolved, because we've got to be getting on with the job. And that's because the job has got more challenging, particularly at the front door, with our ambulances have been queuing. And quite apart from that, you know, we've got waiting lists which are absolutely ballooning everywhere, and a huge jump in this. And I'm really worrying about the people that are sitting on that waiting list. And I'm worrying about the workforce that's trying to deliver that. Because whilst the number of hospital doctors has increased brilliantly, and the number of admissions has increased, and our population has aged, our number of GPs is dropping. So we are in a hugely challenged place with the system that we're working in. Parts of our population, if you look at households in Cheshire and Merseyside who live with physical disability, mental health problems, drug or alcohol misuse, and children who are in the care sector, astonishingly, those households make up 8% of our population. And that 8%, even more astonishingly, is consuming 36% of all of our resources. So what we face now is one of the most enormous challenges to get this right. We know that. We feel that every day, don't we? So we've perhaps got to look to the future. What is it going to be like? Maybe it's going to be super-duper operating theatres. Maybe it's going to be fully bionic. Maybe our chips inside us will monitor our renal function, our liver behaviour, exactly what's happening with the serotonin levels to support our mental health. And of course, the panel of oncogenes will flag when we are potentially heading towards a cancer. And all of that telemetry will be managed centrally. Maybe. So, what I want you to think about today is backcasting. I want you through today to think, what is that perfect future where the work that you all do, managing the way we have our data and our health intelligence, what is that going to get to? What brilliant place are we going to be? And then you're going to look back and say, what were the steps that got us here? That is backcasting. What is that properly connected future going to really, really look like? And how, therefore, are we going to get there? The 2 pointers I want to give you is maybe you, as the specialists in this, are going to think about the technical, but we've got to manage the cultural as well. We've got to bring our communities with us. We've got to empower them with their own health and not just be paternalistic in all of this. And people worry about data. And I worry about health data as well. It's worth more on the black market than your bank account data is. And how do we get people to move on? Well, there's something unique in health when it comes to thinking about our data. But let me be clear. Data on its own, I don't believe has much value. But you turn that into health intelligence. It's not often the World Health Organization has a short definition of something, but health intelligence is data that you can action. And it is the action now that must come because of the way we manage our data and we turn it into that intelligence. I'm now looking at the waiting list. The entire waiting list I can map in terms of people's outcomes, their risk of mortality whilst they're on the waiting list. And their risk of mortality now is along the bottom. And up the side there is their risk of mortality if they wait. Now, most people line up on the diagonal. But nobody gets better by waiting, by the way. But look at that arc that heads up there. I can find groups of patients who will disproportionately deteriorate whilst they wait. And what have I told you I'm worried about? The health inequalities that are out there. And guess what? The highest risk patients come from the most deprived deciles. So they have most to lose. So now we have a program. Now we are prehabilitating, not just rehabilitating, prehabilitating the most high-risk patients on the waiting list. And we find that because of the power of the shared care record. We know their comorbidities, and we are getting them health coaching before coming into hospital. And the impact of that health coaching is we're now reducing their length of stay, we're saving over £1,000 per patient, and we're not readmitting people with chest infections, because we are supporting those at highest risk of chest infection before they have their operation. Their other complications have reduced as well. So I worry about the entire waiting list, 33,000 sitting on the waiting list, and using Cypher, our population health, I can start to cut that down and say, well, okay, who's waiting for hip or knee replacement? Let's get down to those 35. Who's waiting for hip or knee replacement and is diabetic? And whose diabetes, so we're down to 3,000, and you can pull the slider along, is such that they wouldn't get their operation because they're too overweight, their diabetes is too poorly controlled, but they're sitting at home for a year with their hip hurting more. But now we can find these 249 patients, get them into their GP surgery, and start optimizing their diabetes. Better for them, better for the NHS, and it's fair. And it's equitable. So this is where I want you to get to today. What is it you can do that will turn the insight through these records into real action? Action that will make a difference, not just to populations, but to individual patients who make up that population. And you're going to worry about all of this stuff through the standards, the infrastructure. Think about digital exclusion as well. And I know people talk about inclusion, which I think is lovely, but let's be candid. How do we reach those who are most difficult to reach? What is it that we can do? And we can map this. And I've told you to worry about Big Brother, haven't I? And I don't want us to be paternalistic. Maybe we need to be fraternalistic. Maybe when Big Brother works, it is supportive, it is encouraging, it is empowering, it is enlightening. And it sets our population off into their future, taking responsibility, interacting with services in the right way, building a service that will react to what they need, and really get the health of our population to the very best place it can be. Now, all of you need to be this. When you put your minds to this with your technical skills, your technical abilities, your communication skills today, we're going to get on with those steps. We're going to think about what that future is for all our patients, and you are going to be responsible. Today will go down in your calendar where we started to make that difference. Thank you very much.
I think we can all say we've had two very good presentations, two very good and very compelling, very insightful conversations. One extremely important, and we should put William in every item we consider. When we're looking at what we're doing, how do we make sure that person and their family and carers at the centre of what we're trying to achieve? How can we make sure that that does not happen again? And using our shared skill set and what is the art of the possible and how we make that journey. This summit, which is great to see everybody here, is the engine house that's going to make that happen, as Rowan said. So I think the key bit is we just got to get on to the next stage of the event and then start making some of that action happen. And let's do it once and share many. We're too often we don't share that level of knowledge, and that's one of the key things of getting everybody today. So again, I think a final thank you to our two speakers. And we're now going to the bit where some people are going to have to move and some people don't. So if you've got an A on your badge, and I'm on about the corner, not on your name or something, then you stay in this room. If you've got a B on your badge, you're going to go downstairs to the Palm Court room. There is two different tracks. Anybody who's got a real issue with a track, we can probably sort something out, but we have tried to mix and diversify the team. So if you happen to be on a technical session, it doesn't mean we're expecting to be techie, we're expecting diversity in teams to challenge the techie.